Good morning. So first of all, I am excited to see so many faces here today. My name is Eldrin Lewis. I am the Simon Sturzer Professor of Medicine and the Chief of Cardiovascular Medicine, and also the Center Director for our SFRN on diversity and in clinical trials. It is truly a pleasure to welcome all of you here today as we kick off the Stanford Think Tank on diversity and health equity in clinical trials. It really takes a village to put this together, and just want to thank the organizers, including Dr. Latha Palaniappan, as well as Dr. Magali Faziota and Dr. Daryl Oakes. Thank you very much for all of the efforts that you've put together in really leading this effort and putting such a great group together. In addition, we have an amazing steering committee that includes Dr. Jazona Alberto, who's the Assistant Director for Postgraduate Medical Education, and our Jill Evans, who's a Program Director for the Office of Faculty Development and Diversity, Lauren Haley, who's a Communications Coordinator of Development and Diversity, Sho Clark, who is an instructor and soon to be Assistant Professor of Medicine here at Stanford. Marco Perez, who's an Associate Professor of Medicine. Fatima Rodriguez, who's an Associate Professor of Medicine. Hannah Valentine, who's a Professor of Medicine. Ken Mahaffey, Professor of Medicine. Mame Yadam, who's a Vice Chair of Research and Associates. And Shagufta Shaheen, who's a Clinical Assistant Professor in Oncology. So thank you very much to all of the steering committee members as well who really helped putting this together.
Good morning, everybody, and welcome to Stanford. And for those of you who are from Stanford, thank you for attending this important, I think, game-changing opportunity. And I want to thank Eldrin and Latha in particular for really seeking out the funding and the motivation to get us all thinking about this in a very granular and operational way. So we all understand some of these issues and have heard the numbers and the data, but we really want all of you today to think about what can we do with boots on the ground to really change things. So what I want to do today is spend 30 minutes or so just talking about something that I think we all hear about, but want to really put it in more of a day-to-day context for all of you. And that is social determinants of health as a predictor of population health. Now, during the pandemic, I gave a similar discussion at the National Academy of Medicine virtually. And I was very worried about giving this discussion because of some of the topics that I was bringing up. And I think before the pandemic, probably wouldn't have gone over as well, but during this discussion, it was really, I think it touched a really important nerve for people in the audience, and I had many requests for people to share my slides because they wanted to take them back to their community. So I think this is an area that we all hear about, but we don't understand. So hopefully we can get a little more clarity, and later on I'm sure you will discuss some of these topics. So let's just start with the federal funding and federal goal level. This is an area that Healthy People 2030 has highlighted. In fact, Healthy People has really talked about social determinants of health since 2010. This is, as you probably know, the Surgeon General's overview of the many objectives and goals for health in the United States. And social determinants have been on the list of Healthy People for, as I said, about 20 years now. So really something that we have been incorporating, but I think have not spelled out very well. So these are conditions of the environment in which people are born, live, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risk. And they include things like education access and quality, healthcare access and quality, economic stability, social and community context, and the neighborhood and built environment. And these are not things we traditionally think about when we think about health. And why are these important? I think you've heard, I know Dean Miner has talked about this, many of us have talked about this in our day-to-day activities, but it's really important to see when you look at two studies in particular, one in Canada and one in the United States, looking at the impact of societal conditions on actual health, you can see here in this slide that healthcare really only accounts for about 15% of good health, 15 to 25%. Health behavior patterns are really much more important at 40%, but almost half or more of our social and environmental exposures really account for good health. They're in the dark bars, the dark part of the pie graph. So we see that even if we have access to health care, even if we have access to medications, and even if we account for genetics, more than half of what affects our healthy living and our healthy lifestyle, ability to live long, healthy lives really has to do with things that we may not have direct control over. The air we breathe, the ground we stand and walk on and live on, the homes that we're in, et cetera. And so when you look at conceptual frameworks for social determinants of health, and this is kind of high level, but I'm going to go into some more details later, the World Health Organization also has a conceptual framework, but I really appreciate the Pan American Health Organization's framework best because they really take into account our Western Hemisphere and our indigenous cultures into much more consideration. So if you look at what we're talking about here, there are structural drivers such as political, social, cultural, and economic structures, natural environment, land and climate change, history and legacy, ongoing colonialism and structural racism that actually impact in a very large way all of these conditions of daily life that we just talked about. And some of these are so overwhelming and so set in our cultures that we don't even understand the impact that they have on us. These all lead to either a health equity or lack of health equity and a dignified life. And we have to remember that overlying all of this is intersectionality of social and economic inequities, gender, sexuality, ethnicity, disability, and migration. And then finally, what do we do about these things? These, at least laying them out and naming them allows us to think about how we can take actions around governance and human rights. And this is, again, remember, this is a regional framework, but what this is meant to do is to spur on national governments, regional, local, and even state governments to really take these concepts into account when they are building policies, legislation, and even private activities such as those we were talking about today around trials. So how do we understand drivers of health? This is a busy slide. I just want to show it to you here. It's available on the NIMHD website, the National Institutes of Minority and Minority Health. And this is their research framework. And this actually lays out a really nice pathway for people to do research and to submit research grants to NIMHD. And this is really, the grid includes levels of influence on the x-axis, if you will, and on the y-axis, domains of influence. And this is a way that people can actually focus on their particular research areas and understand exactly where they will be doing work when they start to put their grants together. So for example, you have health outcomes at the individual level all the way to the population health level, and then domains of influence from the biological to the healthcare system. So this actually provides more of a structured framework for us to understand how we are actually doing our research. So how do social determinants of health manifest themselves in the real world? So you can see here economic stability as a social determinant of health. You can see over time that Asian populations do well in terms of median income, white, non-Hispanic, and then you see all races, Hispanic and Black at the bottom of the list. And while we are doing better over time, we are not doing better relative to our counterparts. If you look at education, access, and quality, again, you see that white and Asian Pacific Islanders do well when you measure average national assessments of mathematics for 8th graders. and yet Black and Hispanic children continue to sit at the bottom of the list. Now, how do we get to this point? Again, multicultural, multisocial factors are affecting these. These are not individual data points that you can just change by doing better at math, for example, or teaching math or doing math tutoring. These are integrated into the grid that I showed you earlier around all of the social conditions. And uninsured rates for the non-elderly population by race and ethnicity from 2010 to 2018. You can see again the big disparities that we see in access. And fortunately, the Affordable Care Act has helped to address some of these, but really not have addressed all of the disparities that we continue to see. And so, again, another marker of access, and not only just access, but the fact that these are individuals who live in conditions where they may not have social and environmental access to good health as well. So this is the key that I was worried about presenting so a few years ago to my National Academy of Medicine colleagues, but I think it bears calling out and being very explicit. This is the house that racism built. I think a lot of us have talked and heard about the impacts of structural and institutional racism. And I'm sad to say that if I were in some states in this country where I just came back from, I wouldn't be able to show this slide probably. And so I think it's important for us to call this out and be very specific about how one of the main aspects of why we have inequities has to do with racism. And again, not calling out individuals, we're talking about racism as a societal threat and as a societal system. And you see that there are social forces, political, legal, economic, religious, cultural, and historical events that have a feedback loop into racism and then loop back to really perpetuate those societal forces. These lead to cultural racism, such as stereotypes, stigma, and biases, institutional racism, which I think has a very, very strong impact on the way our children grow up, and then individual discrimination. Again, leading to all outcomes that are less sufficient for many of our underrepresented populations in all of these areas, such as income, education, employment, housing, all of the statistics that I just showed you and more, as well as individual and collective resources, social resources, and I would also think that resilience is in there as well, that we start to deplete the resilience of these communities. And these then, again, feed back to stereotypes, implicit biases, explicit biases, and stigma, and serve as a feedback loop. So this is a system that feeds on itself. And if we don't understand it, if we don't see how it's working, we can't dismantle this. And so this is really important to recognize and to try to address in as many scientific and evidence-based ways as possible. Now, let's talk a little bit about distrust in the medical establishment. You heard Dr. Lewis mention this. We know that there is historically rooted distrust of the medical establishment for good reason. We know that Henrietta Lacks had her cervical cancer cells collected without her consent, and there was recently a settlement regarding this. And we've had a long history in the U.S. Of forcibly sterilizing Black, brown, and indigenous individuals in this country. And there's ongoing institutional oppression. So Blacks and Latinx individuals represent 30% of the US population, but only 6% of participants in federally funded clinical trials. And when we've really seen now that looking at cutaneous literature on cutaneous manifestations of diseases, for example, such as COVID-19, and before the pandemic, it was really unclear that people on how to find access to pictures that represented more than a very narrow range of skin tones. So this has become another area in which we, again, it's so overwhelming, we don't actually pay attention to these issues, but if we're working with patients, if we're trying to deal with patients, and we have a very limited range of access to different types of patients, we are really affecting the medical establishment and the ability for the individuals and providers to trust that system. So access to quality health care is also a social determinant of health. And inherent in that is the fact that we need workforce diversity, and therefore a lack of workforce diversity presents a barrier to quality. We know, for example, some studies, including one here done by one of our surgeons at Stanford, that underrepresented minority physicians are more likely to care for minority and vulnerable patients and to conduct health disparities research, and actually those patients can actually do better. I've also heard pushback from people saying, well, does that mean that I have to match my patient up to their sociodemographic profile? And that's really an overreach. That's not what we're saying. What we are saying is that racial concordance in general, especially in the overall workforce, especially in the healthcare system, really leads to a culture shift within that workplace so that all individuals, those who are allies, can become, those who are not underrepresented can become allies and can actually help to work so that we wind up with longer and more satisfying visits, higher preventative service utilization, and greater access to needed medical services. And this is an example. So there are at least two different major pathways for how provider implicit bias can impact disparities. One is direct judgments and decisions about patient care, which may actually be implicit. These may not be something that are consciously thought of, but there may be certain inherent assumptions made about certain patient populations that will affect the way healthcare is made. If I had time, I would show you there are more examples of how this has actually been demonstrated in the medical literature, where certain races and ethnicities are treated differently, and it is not an intentional effect, it's an inherent implicit bias. In addition, the other pathway is communication and trust with patients, and that's a bidirectional failure. So you may have, the provider may not have trust in the patient, and the patient may also not have trust in the provider. And that leads to either, maybe not a breakdown in communication, but not an effective communicating pathway. And we've seen literature that demonstrates that when you can open up this communication, it leads to better adherence and better outcomes. So let's talk a little bit about who is here. You heard a little bit about the original trial around hydralazine and the lack of gender diversity, and also about equity. Who's trying to get here, but who isn't being allowed in? And then inclusion. And inclusion is really the capstone of this area, because without diversity, we don't have inclusion, but without inclusion, we don't have real belonging and real change. So who's being heard and valued? So you can see in census data from 2019 that the overall population in the United States is 60% Hispanic, non-Hispanic white. But in our own area here, so many of you are from California or the Bay Area, we see that California as a whole and some of our local counties are a majority-minority or a minority-majority population. That is, there is no one group that is the majority in our Bay Area. And even in the United States, we're seeing that more and more populations are rising, and we are truly becoming a diverse population. And we need to address all of our populations if we're going to maintain a healthy population. So I think that's a repeat, sorry about that. So how can social determinants of health be seen in lack of clinical trial diversity? I'm just going to give you a few examples here. So we know that several studies have started to track diversity in our populations and the impact on our clinical outcomes. In one 15-year study, through 2014, across 29 countries, 86% of participants in clinical trials were identified as white. And so that goes beyond the United States, of course. I think this is one of the things I didn't mention earlier. Of course, we want to include the rest of the world, but I think we have plenty to do here in the US. We want to also model some of these behaviors for other parts of the world. And in fact, many other parts of the world are taking these issues on as well. And then of 83 clinical drug trials for Alzheimer's, this is an FDA study across a number of years, 2% of participants were Black. At the same time, Black patients are 54% more likely to develop dementia over a 10-year period. So we don't understand how certain drugs might work in certain populations. You might say, well, why can't we take one population and do trials in them and then export that information to others? Well, there are many factors, social, cultural, genetic, that may affect the outcomes of trials. And so we need to have diverse populations in order to affect them. Not to mention the fact that Dr. Lewis brought up, which is it does bring in more trust from communities if they're included in trials. So when we look at diverse cohorts in federally funded studies, we see some data, which I mentioned earlier, that in 2015, Blacks and Latinos represented 30% of the US population, but only 6% of participants in federally funded trials. Less than 5% of federally funded studies on lung disease included people of color. And as of 2011, 96% of genetic disease studies were conducted using European populations. So this is also hurting our own research. If we don't have a good understanding, especially with genomic research and AI in particular, if we don't cast a broad net and looking at wider populations, we're going to miss key genetic signals. And this is a study looking at disparities of race reporting and representation in clinical trials leading to cancer drug approvals. So this was a study looking at a total population of over 70,000 individuals. Total population and race enrollment was, as I said, was 70,000 individuals. 53,000 of those were white, 10,000 plus were Asian. So you see the percentage of individuals, the proportion of individuals who are Native American, Hispanic, or Black. And these were consistently underrepresented compared with their burden of cancer. And of course, we know, I showed you the data on the distribution of that population in the community. So if we're not including these individuals, it leads to a real dissonance around how we are even doing clinical trials, how we are treating diseases, et cetera. Another area that we were involved with, the National Institute of Minority Health Disparities, a study around precision medicine and racial equity. And that was our SPHERE platform, which we've been working with now for over 6 years. And what we saw there was that we were really not focusing on population genetics. So pharmacogenetics is another really burgeoning area of research, understanding the genetic basis for how drugs work. And if we don't understand those genetic bases within different racial and ethnic groups, we may be actually missing best effects as well as adverse effects of different drugs in different populations. So for example, there have been a number of trials demonstrating that some drugs don't work in certain race and ethnic groups. And so individuals not only are not benefiting from those drugs, but there's also been perceptions from providers that these individuals are not adherent to their drugs because they're failing the drugs, when in fact they may be adherent, but the drugs may not be working for them. So really a whole web of disappointment really in the ability of our federally funded trials to really meet the needs of all of our populations. So what are priorities for increasing diversity in clinical trials? Well, all of you probably have some interest in this area, and so I really applaud you for taking that first step. But we need to think about ways to reach marginalized populations. And clearly, it's not an easy task. If it had been, we would be there already. This is, in many ways, a personalized task. We need to really reach out to our local communities and use existing community engagement structures with local leaders, community and faith-based organizations, community groups, and health centers. My own research is in global child health. I've worked in sub-Saharan Africa, in Latin America, and in India on vaccine and other infectious disease trials over time. And all of my studies were really individually sponsored primarily by federal funds and by US foundations, but the first step for me involved the arduous task of going out into the community and building key leadership relationships with those communities, working within the community's cultural norms and understandings. We can't go in, walk in the door and say, we are here to save you, we're going to make you better, or help you live long lives, and you're going to listen to us. It's first of all, we're way past the time when we can even think that would be possible. But it's really insulting to the local communities. We really need to give those local individuals credit for their leadership skills and their understanding of their own local cultural context and norms. And these are the best relationships. You really have to work, but it takes time and it takes effort. Years ago, when I was an assistant professor, just starting off with my first R01, I was at a meeting. Tony Fauci from NIAID called a group of us together to ask us, how can I really support global health studies? And one of the things that all of us said is, you need to give us more time. We can't just get an R01 and run out and do a study in 3 or 4 years. We have to build a community involvement over time, and you need to help us do that. And he did listen. He started to set up global network leadership networks, where we could actually go into communities and build bilateral administrative and research dyads, where we took leaders from developing settings and partnered them with individuals from existing funded programs, so that we could eventually hand off the leadership to those individuals. And that work was successful for many of the projects that I was involved with. So it can be done, but it takes time and it takes effort, and we need to be very intentional and genuine about the way we make those relationships with those individuals. Even in our local communities, so I'm talking about global here from my experience, but our local communities as well. And we need to not only do that, but disseminate transparent and comprehensive information in multiple languages and in an accessible way. So we have to work with communities and not for them. I'm going to skip this slide because it's too hard to read, but it is patient barrier. In case I put some of these in here in case you have access to these later on, because this is a whole list of patient barriers, Tier 1 solutions and themes, just to show you how complex this issue is. Again, if it were easy, we would have done it already. But these are a number of ways that we need to address these. So mistrust, lack of comfort with process, lack of information, time and resource constraints, and lack of awareness. As a pediatrician, I can also say, having dealt with our local community children, we have to do a little extra to make sure that our children come into clinic. So we have that on-the-ground whole family approach already. And we have to realize that we build services for families so the children can get in and be seen. And this is, again, working with families as partners. And that's, again, my own approach has been, when you work with the community as a partner, you will really wind up doing a better job in understanding trust and adherence, and ultimately better patient outcomes. So briefly, what efforts can we make to improve SDH? Well, again, we're going to hear from our colleagues from the Food and Drug Administration. I know the FDA has been working very hard, certainly during the COVID-19 pandemic. They worked very critically to make sure that our trials around treatments and preventative measures, preventive therapeutics were really carried out in a very diverse and inclusive way. Race and racism needs to be addressed, clinical trial design, statistical methods, and community engagement. And these are the 4 areas that you heard Dr. Lewis mention you're going to discuss today. So I want you to think really hard about how to address these issues. They're, again, not going to be easy. We're not solving the problem today, but this is the first step for us to be able to start to talk about how can we really make a difference in these really important areas. And by the way, as a scholarly academic exercise, this is a way for young faculty to really build their careers, because there's so much information that we need to build and understand. It's really an opportunity for people to build their scholarly careers on this platform. So these are some key questions. How does racism manifest in clinical trials? How can stakeholders play a part? How can we work with government agencies to support diverse, equitable, and inclusive trials? What are key considerations for clinical trial design? This is a really important one. This is boots on the ground work. And how can academic researchers and industry collaborators partner effectively with the community to best serve the needs of the population in clinical trials?